Welcome, everyone. We'll give it a few minutes to get started. As you can see on the screen, Leveraging Telehealth for Behavioral Health Challenging Times is an upcoming webinar you might not want to miss. And you're here for an innovation webinar. Just make sure you're in the right spot. All right, I'll go ahead and kick it off. Thanks, everyone, for joining. I first want to thank Lori and Lisa at Invive Solutions for making all of the webinars and behind the scenes possible here at the New Mexico Telehealth Alliance. They are both absolutely wonderful. This is going to be an interactive session today, so feel free to throw things in the chat. I'll make sure I'm reading it. If I have missed it, feel free to unmute and let us know. What you're going to hear today is the ups and downs of digital innovation in healthcare by Alex Carter. This is one of our wonderful webinars this fall. They are being recorded, so they'll be available on the New Mexico Telehealth Alliance website if you miss anything or want to pass it on to others. If you don't want to be recorded, make sure your camera is off, although it will be incredibly small and I can't imagine anyone will see it. It is recorded. And feel free to rename yourself. It looks like everyone's done a great job of putting your name in there. And if you want, please introduce yourself in the chat with your name and organization so we know who's come and it's helpful for questions and answers. We're going to make sure to mute you. So if you need to come off mute, make sure you do that. And then again, just a reminder, put questions in the chat and I'll make sure we get to them as it makes sense so we don't interrupt Alex. Although her and I are easy to interrupt. We're friendly, like questions, so feel free to bring it on. And I'm going to kick it off by introducing Alex. Alex is a wonderful friend of mine in addition to being great at innovation and healthcare. So I'm excited to introduce her. She serves Presbyterian Healthcare Services Innovation Hub. It's an arm of the organization that is an intersection between healthcare and innovation. She's actually a certified physician assistant, so she also practices and acts as a clinical counterpart for the innovation officer and really works as that clinician-specific voice that helps make sure the work is considering those that are practicing. In her role, she's been a key player at helping to roll out asynchronous or text-based, email-based sort of visits for Presbyterian while expanding telemedicine services and really pioneering and implementing the Tyto devices that help enable remote physical exams, Medical Advantage products that they're rolling out, and the health plan to really serve members with their sites and clinics where the member is and in a really affordable way. Before she came to Presbyterian Innovation Hub, she worked full-time at their medical group as an urgent care provider and helped build out the first telehealth service, online visits, and she still practices there today. As I said, she works as the voice of the user from the physician side. She was actually raised in Vancouver, British Columbia, where she was a professional voice actor for 12 years. And she graduated from physician assistant school in Philadelphia, moving to New Mexico in 2017 with her husband, who serves on Kirkland Air Force Base and hasn't looked back. She's got such a cute daughter named Scout and a cat named Abby. She enjoys pottery, vegetable garden, and all sorts of other nonsense that she can get into with the fam. So I welcome her and appreciate all of you joining today.
Oh, that was such a nice intro, Stetson. Thank you so much. Thank you. I'm just I'm looking at the chat, trying to see where everybody is from today. I'm really happy to be here. I'm very happy that I was invited. I work with Christine David quite closely. I know she's part of she's a member of the Alliance, and unfortunately she wasn't able to make it today. That's probably good because she would probably seed my intro with some, barbs and insults because we're actually that close. But I know you guys do a lot of great work, and so I'm honored to be able to participate. Today, I wanted to talk about innovation, quite specifically telehealth, because that's our jam. But from a lens of ups and downs of the reality, the real talk, so to speak. We often speak of telehealth in the framework of the promise, right? The promise of telehealth. So many promises of telehealth. And I believe wholeheartedly in the promises of telehealth. But then there's also the practice and the reality. And sometimes reconciling that is difficult. Sometimes it's difficult for us to move past downs and back into our ups. And it's also difficult when we're trying to maintain the narrative about telehealth to the people we work with, right? When you have an initiative that doesn't go as planned, people can be really quick to judge the entire concept of telehealth, right? And so how do we bounce back from that and maintain the trust and interest in that? So I'm just going to share my screen real quick. Here we go. Okay. So first, I just want to do the little disclaimer that these are my own opinions. These do not represent PHS. And that's, self-explanatory there. I wanted to start this by framing a little bit about the PHS Innovation Hub. It was started at the beginning of 2017 by Dr. Reese Robinson and Jessica Lynn from Presbyterian Healthcare Services, and its mission was to be a strategic accelerator, and by doing some very targeted identification and implementation of innovation. Sometimes these innovations are physical tools, sometimes they're concepts, sometimes they're staffing strategies, but whatever they are dedicated to improving the experience for patients, providers, members, as well as reducing cost of care. All of those aims that we share. We tend to use this little grid. It refers to the core, adjacent, and transformational innovation realms. These are some of the projects that we've been working on over the last few years and how we categorize them in the framework of core, adjacent, and transformational. We've got our next generation digital experience, which is a in-house built new digital front door. So it's all of our websites, all of our portals, and we've been really fortunate that we have developers on staff who are able to build this according to our needs. We have different tools within that, like an appointment tracker. Think of the Domino's Pizza Tracker app. That's what this was based after. Transparency and the ability to feel involved in the process that tends to be quite opaque. Tyto Care, which is something I'll talk about a little bit today. We're doing a transformation with our Medicare Advantage program. We have a really robust intelligent automation or remote process automation group that do some really cool things with bots. And then Graphite is a new organization that our Chief Innovation Officer is now focused on. And it's, I can never speak to it very intelligently, but it's focused on interoperability, all of the different things that means. But I always, I hesitate to go into details about that because I really can't speak well to it. That being said, it's clear that we like to span that whole spectrum from core through adjacent and transformational, understanding that we have, you've got those mission A and mission B at the same time. Mission A being keeping the lights on, doing things at, just going, the day-to-day activities and the day-to-day keeping patients healthy. And then there's that mission B of, okay, well, on top of that, we also need to innovate. We also need to try new things. And so by spreading our topics and our foci across this entire spectrum, the goal is that we're able to do things that help A and do things that help B. Want to show you just a little bit about some of these different things that we're doing. I won't spend too much time on these ones, but we do have this digital operations team, and what's really nice is that we've got a vertically integrated team, and they are embedded in our operations. So they work with scheduling and they work with our providers. They work with really all the operational units across PHP and PMG. And so they're doing a great job creating tools that are representative of the operational needs. This is our intelligent automation, really cool team. A couple of years ago, it was literally just one person and about 40 bots. He really loved to name all of them though. So he would list out his team and they would have all these names. And then he'd have this joke at the end where he'd admit, oh, they're not people, ha, ha, ha. Now he actually has people too. So he's got quite a large team of folks as well as many, many bots. And the goal of this being that we want people to be working to the top of their license, to the top of their scope. And that's kind of, I think, we always say that, but maybe a better way to say that is people working in the most meaningful human ways. So there are some things that just are, are better suited to a computer, but then there are so many other things that if we could redeploy humans to, can give what only a human can do, that personal interaction, the empathy, sympathy, experience. And so that's what the Intelligent Automation Group does.
Alex, sorry to interrupt. Would you go back 2 slides to the vertical integration? I had a quick question. Something that I've seen in these larger organizations is you have analysts and developers and these things that you work with. Are these individuals, does your innovation team pay for their salary, but they live in the analytics department and are just dedicated to you? Or are they actually analysts completely under you full-time that sort of are removed from the analytics department? Can you describe sort of what that looks like quickly?
Yeah, absolutely. So there's been a bit of a progression there. In 2019, under the Innovation Hub, we started a branch called Next Generation Digital. So we have a chief digital officer, which was housed under the Innovation Hub. And then I think we started with three analysts and developers. We're now at 17. And over the last year and a half, they've been transitioning to their own department. So they haven't at any point been absorbed into analytics or into our IT department. They've maintained their autonomy there. And because they're growing, they're kind of, like that exocytosis thing where you get like a little blob of your cell coming off. So they're another little blob with their own independent budget now. I hope did that answer?
Yeah, I've seen it done a bunch of different ways, so I thought it might be helpful to know how press is handling it.
Yeah, and I don't lead this team at all. I'm just one of their colleagues, but what I would say is that having the autonomy that really could only be afforded by being in something like the Innovation Hub, which is, it's not delivery system, it's not health plan, it's not IT, it's not operations. It has some of this nebulous nature to it, I think gave them really unique opportunity to figure out what they were before somebody else told them what they were. So very fortunate to have that opportunity. Zip through that. So many bots, lots of claims bots, call center bots, things that, for example, monitoring returning voicemails. Obviously, we want to do things like avoid penalties, but we also want to take off some of that, mental labor of trying to keep up with all the different things that we have to do, and then spending that time and energy actually interacting with our public. So now we get to the pith, the good part, telehealth. Telehealth, intelligent automation, and digital were really the 3 main groups under the Innovation Hub. And I've spent most of my time in that telehealth world. Stetson alluded to my experience as an urgent care provider and being a provider within the telehealth set of venues. And so I love telehealth. I have so much gratitude for it, so much gratitude for what it affords both patients and providers to do. Stetson's heard this one a bunch of times, and I won't say it in too much detail, but I really struggled with in-person care delivery. I struggled with it a lot. It was, after all those years of school and all those student loans, it was a real disappointment for me and a real sense of failure when that didn't work out the way I'd planned. But because we had telehealth, I had this other option. And I was able to continue, and I still am able to see patients and treat them and have that relationship with them and create the access that I wouldn't be able to do if there wasn't telehealth. And so I have a lot of gratitude for that. And I think that it's an incredibly important part of how we interact with our providers and our care teams, because it really shouldn't be a binary that either you're in clinic or the hospital or you're not practicing. I think telehealth is just a wonderful way to be more inclusive of people with different abilities, disabilities, who have different caregiving responsibilities. Of course, COVID really highlighted that in so many different ways, but not even thinking of a pandemic or of infection control, just thinking about the flexibility that telehealth offers people, I think is something that, I'm really passionate about, and it really leads everything that I try to do. So I'm sure you'll recognize this. It's representative of the spectrum of care, with the left side being the least acute, least complex, least expensive, moving over to the right, where you start getting more complex, more acuity, and consequently more expense. We like to frame things in the spectrum so that we can understand, where's the appropriate place, appropriate time, and appropriate patient, so that we can have those patients, venues, and providers intersect properly. And it's definitely a work in progress, as you'll see as we're talking. But it's been an important framework for us because it helps give us kind of a common language and a common concept, something as simple as this left to right, just a linear thought, has been incredibly valuable in conversing and trying to translate our goals to folks who aren't as into telehealth, maybe, who don't get the little sparkle that we get when we talk about it. And so I tend to go back to the spectrum a lot. Of course, you'll notice there's a gap there that comes into play later. So I wanted to use a couple things that we're doing and that we've done in telehealth, just as examples. Lots of times we give these presentations and I'm trying to present like what we've done and accomplishments. And I really wanted these to be more opportunities to talk. And so I have to say some of these numbers, as you can tell, this is 12, 6, 20. They're not today's numbers. I'm not trying to give updates on exactly where we are, more about where we've been, what we're doing, and how it's, informed where we are. So this is a beautiful pie representing our Presbyterian medical group. This was the split of our traditional in-person appointments, telephone appointments, and telehealth video appointments at the height of COVID, right? So this is in December of 2020. This was really the peak of our telehealth. It did go up and down, it continues to, but this is system-wide. So we had quite a high utilization, and if you include telephone appointments, many of which were actually failed or incomplete video appointments that had been attempted, look at that, that's more than half. So, from a telehealth perspective, being an advocate for it, I was just so excited about that, right? Like that 20-year roadmap that we all had back in 2019, where we were thinking one day we'll get to 30%, and then just here we are.
Overnight.
Overnight, right? Overnight. We all.
Sorry, Alex, to interrupt real quick. That I'm gonna out myself as a millennial. I use my telephone for everything but a phone, of course, as you can imagine. The telephone, you mean audio only, and when you say telehealth, you mean video only. And correct. Traditional, you're talking about face-to-face, correct? Just to make sure.
Thank you.
Okay.
Absolutely. Yes. And so our terminology has changed since then. We don't, default to calling something traditional just because it's the way we've always done it. We have some more descriptive descriptors now. But when, I talked about the promise versus the practice, and we talked a lot about the promise, the height of COVID, because it's true. When let's say we've got one pie, finite number of slices, and we're shifting slices to telehealth, that could give us an opportunity to create a one-to-one reduction of our in-person visits, where we had all this infection control, PPE limitations, surges, all of those things it was so important to keep people out of the clinics, right? So incredibly, critical to do so. And a lot of how we oversimplified it, and this is the broad worldwide we, a lot of how I think healthcare's oversimplified it was that, okay, well, if we do this, then you're not going to need this other visit. And we really didn't find that, right? That's not what happened. There were some places where that worked really well, behavioral health being one of them, where they already had an established practice with their patients through telehealth. But what we found was that for many reasons that it wasn't a one-to-one. We would have telehealth and then we'd have a duplicated visit to kind of finish up that telehealth, or to do the thing that the video visit was intended to do, but for whatever reason it couldn't do. And one of the things that really stood out for us, and it's ironic because I was having trouble getting on this call earlier, but we started by using Zoom as our telehealth platform. And for our population, downloading that app was absolutely insurmountable for many of them. It was absolutely insurmountable. And if you we take for granted the many steps, as millennials, the many steps that we don't even think about to get onto these apps and to engage. But there's A, having a phone, B, having access to Wi-Fi or having a cell phone plan, knowing your password, knowing your Wi-Fi password, knowing your App Store password, getting the app, understanding how to download it, wondering, is this going to cost me money, worrying about your personal information. I mean, so many different things that would be barriers between wanting that appointment and actually engaging in that video appointment. And it was really disheartening for a while that we were having that, because we had the will, patients wanted to do it, providers wanted to do it, but the technological barriers for a long time were just absolutely insurmountable for some people. And so what that meant, though, is that we were trying a lot of these visits, and then a high number of them were coming in person anyway. So for that provider and that access, we were actually reducing our access because we were duplicating and increasing some spend there. And I always hesitate to use a word like failed. I feel like in this sense, we understand we're talking about like a failed technical connection, not a failed, human encounter. But that is something that we've really learned, is that we really, increasing telehealth is not the goal. Just pushing numbers is not the goal. The goal is to use it meaningfully, responsibly, appropriately. And sometimes that means not using it, right? Sometimes it means recognizing when there are some places where there's a low probability of it being successful for the patient and provider, and focusing on those circumstances where we think it might be more successful. So I'd love to, I know you have the questions going into the chat, but I would love if anyone has experiences on the platforms. If you want to put that in the chat or make a comment before I go on to another example. Take silence as a no.
Alex, you're well aware, working with me at UNM, that we have the same Zoom challenges. I mean, we called each other and tried to figure out how we were each helping patients get on. And, every app, regardless, every app realistically presents the same challenges if it's an app. Yeah. It's really only a web launchable solution that mitigates most of those issues, but not all, for sure.
Absolutely. No, we experienced this together, and it was what a journey, right, Stetson? What a journey. And I wanted to show you this other pie, because what happened was we figured this out and we tried to overcome these barriers. We tried with education and we tried with training, but it really just wasn't working. And so we had to make the decision to switch. And so we found Doximity, which was web-based. It is a text message that our patients receive. They click a button, you authorize the video and the sound, and that's it. So there's no sign-in, there's no app. And this, gosh, I wish I put the date on here, but this was in a couple weeks of implementing it. We had gone from 100% of our video visits, successful or not, being with Zoom, to 8%. And now I think we've got under 1%. Can't remember which group is still using it for part of their visits, but we are, incredibly quickly, people adopted this other solution because when we accepted that these barriers for the time being and with our resources were insurmountable, when we made the move, that was a success, even though, and I don't think that using Zoom was a failure. I think it was a really logical thing to do. It's a great platform. We use it today. It was very secure, but, trying to fail a little bit faster than to just hold out and keep pushing through, like, okay, maybe in 2021, we'll try something new. I think that was something that I'm really proud of, is that we didn't hold on super long. We understood the gravity of the situation and said, okay, well, that didn't work. Let's try something else. And of course, that has challenges too. When you pay for a platform or you pay for investment in something and then you say, never mind, let's shift. Of course, it's a lot more nuanced than that, but that can sometimes be the impression that the rest of the system gets, which is, what are you doing? We have a platform. Why aren't you just optimizing it? And so I think this has been a really interesting challenge as well, to create that messaging that, it was expensive and it didn't work that well, but here's why, and here's what we're doing, here's what we're learning from it.
And I know that there's probably a lot of people on the call that don't know that software, Alex. Just to sort of maybe
Yeah.
wrap that point up in a bow, it sounds like what happened were there was insurmountable barriers for the patients. You looked at what they were and you chose a software that mitigated those barriers. And in this particular instance, because I know about it, I can say that it was because you're removing the whole app piece. The patient is getting a text message and it launches the web visit without the app store and the app and using the app differently. Is there any other things that, maybe just to finish that off, that you thought were key to the success of quickly transforming, or was that it, was just responding to those barriers?
I probably am not going to do justice to all the work that was done to do that. It wasn't as simple as this one switch. But in many ways, it was as streamlined as that switch. We said, we've heard you, forget what we taught you before, click this one button. And it was mostly that our providers were so excited about the improvement for them, so that they were doing the advocacy. They started to schedule them more, because we saw a really steep decline with the Zoom visits too, because the providers just weren't having success, and it was incredibly frustrating and disheartening. But as soon as we had that new tool, I think their advocacy made all the difference, because they were promoting those visits and suggesting those visits and being willing to complete those visits too.
Yeah.
So here's another example. We have a program at Presbyterian called Online Visits. Online Visits is an asynchronous telehealth platform. So by asynchronous, we mean it's not this. It's not live audio visual. It's storing information and forwarding it. So you not only get to separate people in space, but you also get to separate the patient and provider in time, which creates some incredible efficiencies. And again, when we talk about provider experience, it creates so much flexibility for a provider. And then from the patient side, not having to pull out your phone to do video in the middle of the workday, you can do something quite discreetly. There's a lot of privacy attached to that. I could go on forever about, how important I think async is to marginalized populations. But to focus on this, a lot of the promise for async was, it's not letting me do my real fun animation. There we go. Oops. Go back. So the promise was that this asynchronous would have this efficiency that then just totally freed up primary and urgent care. And so it was kind of that same promise of video visits, that it would be increased access, one-to-one. And in a lot of ways that did come true. In a lot of ways we were able to free up some access. But what we did actually find more with asynchronous was uncovering unmet need. I think we had a lot more people who weren't able to use our other venues at all that were now using this venue of care. And so that was an interesting surprise to grapple with, because that wasn't our anticipated initial outcome. I think there's a lot of success in that. We have a lot of use for birth control, emergency birth control, smoking cessation, and then of course all the other urgent care things, respiratory, yeast infection, things like that. But it really gave this unique venue to people who may not have been able to access other means of care. So great success there, I think,
Alex,
particularly clinically.
Sorry to interview. Are you also using this as a triage tool? So when, I'm assuming you can't. Okay.
Yeah, so it is different than a triage tool. And the one difference is that the form, like the branch logic form that the patient fills out, goes directly to a provider. So there's the system is quite sophisticated in that it will bump people out if they meet any of the clinical criteria that we would not want them to be there for. So, high fever, shortness of breath, chest pain, things that we just absolutely can't treat.
And then they're scheduled in person.
Yeah. So the system would do some triaging, but once it got to a provider, it was just there. But the beauty of that is that one interaction led to treatment. So it didn't have to be bounced from a triage to the provider. The triage happened automatically. The provider would get it, gets it today. I mean, I had 102 patients 2 Thursdays ago when I was on shift for the day. And so real efficiencies there. But what we discovered in reality was that we had a lot of patient desire, but we had some pretty big gaps in provider comfort. We had a small group that piloted this of providers, but of course we had some selection effect, right? The people who volunteer to try new things like new things. People who volunteer for innovation like innovation. It's not good or bad, it's just the way it is. And so I think our perception of our provider uptake was a little bit skewed by our pilot group, because they were loving it, right? They were so comfortable with uncertainty. They just had the temperament for this. But as we started to scale and expand, and particularly when we tried to expand into pediatrics, it just became very clear that provider comfort was going to be properly imbalanced against our patient desire. So we would get that same repeated visits. The patient, the patient would go through the system wouldn't bump them out. They'd get to the provider, and then the provider would bump them out, right? We call that a provider escalation. And technically, based on the algorithms, based on the clinical oversight that we have, and we were very involved in these algorithms, technically, all those patients who came forward and made it to the end of that queue would be technically appropriate to treat. But our providers are humans too, right? They have that sense, they have experience, they have a gut, and all these things that aren't quantifiable and can't be put in an algorithm. And so I would definitely never say that was a problem. That was just the degree to which that was imbalanced was a surprise. And so we were just repeating a lot of visits. And as you all know, in New Mexico, we've got payment parity for asynchronous. And so these are billable visits for us. So our providers are paid. We pay the platform for, providing the service to us. So those were repeated visits. And from a purely financial point of view, it was very expensive to repeat those. Very inexpensive to do one, not quite as great to do two, to send them in person. So that promise of being able to replace and free up access, that was difficult to prove out. On the other side, we got some unexpected clinical benefits, like from marginalized populations. And then that patient desire versus provider comfort, that one persists today. It's not just the providers who provide this service, but it's the primary care providers of those patients who are using the service who, they don't like what they're seeing. They don't like the concept of it. And so I think there's still a lot of work to do there. And that part of that is the narrative. Part of that is using some of the learnings from COVID and that forced experiment of, okay, we actually have some robust data now on what asynchronous can do. And it's not just ours, it's from across the nation, from across the world. So there's still a lot of work we have to do there. And when we tried to mitigate some of this by making an easy transition between this asynchronous to a synchronous visit, we had very low provider adoption there because despite some of their low comfort with the platform, they love the convenience because you do this in your PJs on the couch. You don't ever have to show your face. It's incredibly convenient, right? And so when we asked our providers to then get on camera, that was a good 6 months of just, constant failure on our part. And poor Christine, if she were here, I could just see her, struggling to remember it because it was rough. And so even though it made perfect sense that you would, go from asynchronous to asynchronous, makes perfect clinical sense, there's the human aspect of it that we didn't anticipate. And that didn't work out. We have a slightly different workflow where we refer to a different pool of video. We're getting some traction there, but that was a big surprise. And it kind of, it tarnished a little bit our relationship with those initial providers when we asked them to do that, because their initial agreement was to do the asynchronous. And I think we pushed this, and then we had to do some repair to get them back and to have them trust us again. So I know, actually, I think we're coming up on time, aren't we? I don't want to, Laurie, what's the?
Keep going, Alex.
No, I don't want to go over time.
You still got a few minutes. Go ahead.
Okay.
And there are, and just so you know, there are a couple questions in the chat. One is, what is Presbyterian doing about reducing repeated visits? And the second, well, there's 3 questions. We got all kinds of questions coming in.
Ooh, sweet. What are we doing about repeat visits? Well, that for asynchronous, we actually worked with the vendor who created the platform, and we helped them build in this escalation button that would take you to video. Again, worked really well in theory. That didn't work as well, but now we have this other pool of providers so we can refer click of a button from async to synchronous to a group that's more inclined to want to engage in those visits. But I'd say we still have about 15 or 20% of these visits that are in this nebulous disposition phase. Some of them are fine. The patient leaves happy, they get the treatment they need. And some of them are like, gosh, should we have gotten them somewhere else? Or, just this face that you make, when you're not quite sure of how something turned out. And so we're still working on that.
And is that tracked by provider, Alex?
Yeah. So
Good
I have a really high escalation rate. That's something I'm constantly looking at. I have a lower comfort with some uncertainty in some things. It's actually dependent on the body system for me. And we have people who range from 2% escalation to 30% escalation. So it is very much based on their experience, their comfort, and their disposition.
And my experience at UNM, that would have been based off specialty as well. One of the pediatric specialists said, I would love to treat pictures of rashes on children, and I could do that via asynchronous all day, every day, because I don't often or hardly ever have to do a biopsy on a child. They're like, I don't want to treat adults, the same dermatologist. I don't want to treat adults with asynchronous. I'll use it as a triage tool. I'll say, okay, you need to come in sooner than someone else, but I likely have to do a biopsy. So even in the same specialty, the age group and the comfort could vary. So I can imagine that was very difficult to build in all of those rules. And I know, Dale, you could probably answer this as you're going forward, but how are you documenting sort of these telehealth counters? It sounds like that's integrated into the EHR with an interface, I would assume.
Yes. So for our Doximity and Zoom visits, initially they were side by side. So we had Epic open, we did all our documentation there, and we just had a screen beside us, right? Then we integrated Epic, and then we integrated Doximity. So you launch the visit right from your provider schedule. So but you're still really in essence doing a side by side, right? Because you launch it, it goes into your second monitor, and then you have Epic here, and you're doing your documentation. That one's great because there's no transfer of information. It's natively put into Epic. For asynchronous, when we use this third-party vendor, we have really basic CCD integration. So the continuity of care document, it's sent, definitely not real time, but it's sent dozens of times a day, but over to Epic. It comes in. The best way I can liken it is like a PDF. So it doesn't have discrete data fields, which is a real frustration because it doesn't update your med list. It doesn't update your allergies, problem list, and things like that. So not an ideal integration there, but we do have the data there. And so for our providers who are in Epic, all of them in PNGR, they can easily go in there and look at it. It's just the issue of it not having those discrete data fields.
And I'm guessing if you can do Tyto Care in 7 minutes or so, we'd be good. I know that'd be hard because you're passionate about it, you pioneered it, but.
Yes, I'll go super quick. Tyto Care it's a handheld medical device. It has attachments on it for looking inside your middle ear, your nose, your throat, gathers high fidelity heart, lung, and bowel sounds, as well as has an infrared thermometer. Can gather. You can get attachments for blood pressure, pulse oximetry, as well as weight. And so, this little table here is quite illustrative of that. What we're doing right now is a video visit. And of course, if I needed to hear your lungs, we could not do this. I would need to have you come in. If I needed to see your ear. So the promise of Tyto Care is that now we can do that. You have this device at home, and I am hearing that. Now, what I want to say is that it's an excellent tool. So the promise of the technology, I would say, is really well realized. Incredibly high quality sounds. Our cardiologists, pulmonologists, they love it. They think it's like, they're impressed by it, right? Fewer artifacts than their Littmann stethoscope. ENT, they love this fact that there's an eardrum the size of their computer screen. It's just gigantic. It's really cool technology with really, really good clinical data. But as we learned before, good technology plus people, aren't necessarily the same thing. So we've got our enhanced clinical scope. This is just, we are the exclusive distributors of Tyto in New Mexico, which is something that's been really important to our strategy, because in trying to help our Medicaid and Medicare population, as well as increase our commercial market, this is a nicely differentiating tool that no other health plan can offer in the state of New Mexico. Go over this really quick. We do have it integrated with Epic, so it is that same integrated button within the encounter, as well as it's integrated into the Epic flow sheets. So the vitals tracking. So when you get any sort of structured data, structured numerical data, like a heart rate, blood pressure, temperature, anything that isn't a sound or an image, it goes actually right into their Epic flow sheets. And so as we're building it out, we see that as an opportunity for remote patient monitoring and for that hands-off tracking, baseline variation tracking. We started cardiology. We had a cardiologist out in Lincoln County who was leaving. He needed to go into Albuquerque for a few months, and his patients were going to have to drive to Albuquerque to see him. That's a long drive, and most of his patients were significantly compromised. They were cardiology patients, and most of them were seniors and had some transportation issues. So it was a perfect initial use case. We gave his nurses at LCMC2 these devices, and then we would connect in to Dr. Sunderman Albuquerque live. He would listen to their heart and lungs live, and he completed 820 visits within I think it was like 4 or 5 months. 670 patients spared that trip. He had an incredibly low duplication rate. I can't speak to it offhand, but if he used this tool, almost, I would say it's probably 95+% of those patients did not need to come in. So that he was able to accomplish what he needed to do in that checkup. And that was that was a very satisfying use case, because we knew we were making a difference for those patients in that community, as well as for this provider who really, really, really wanted to continue providing care for his patients.
And was that with Tyto Care alone, or was there other machines at the location that you used it?
Tyto Care. Yep. We had the whole thing. So he had pulse oximetry, we had the blood pressure, the whole kit was there, so that his team remotely could get the whole, the whole picture. I'm going to skip over that, because what we gave away 500 of these to Presbyterian employees about a year ago as our testing group. And so we've had that group, who happens to be a group of both patients, members, and employees, represented both those three groups. Really great group of people. And so they've been testing it for us for the last year. We've got a 25% return visit rate, which is not the duplicated visit, it's the return visit. So they liked it enough to come back. Our net promoter score is 75, and we have a very high medical service rating. So a lot of success there. The promise that we talked about, wider scope, will decreasing duplicate visits, increasing access, but in practice, connectivity. So the tech is fantastic. We love it. Our specialists love it, but you can't do it without Wi-Fi, and you can't do it without broadband. You can't do it without that connectivity. And that is something that we are currently working very, 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 very hard on to try to mitigate. We're working with the state, we're working with our health plan, doing everything we can, trying to be as creative as possible to get connectivity to these patients with the devices, because people love it. You've got that great net promoter score on return visit, but there's that old connectivity issue that we're all very aware of. So with that's it. Yeah. So just the theory of, how do you bounce back from some of these downs is, having leadership that actively states and reinforces failure, like that failure isn't failure, failure is iteration, failure is progress. Without that, boy, is this hard, because you do one thing wrong and everybody, just a chorus of boos. Messaging, making sure that we validate when we do something wrong. That one was really important. I think initially our instinct was, okay, well, we'll just keep trying, not secretly, but behind the scenes, we'll keep trying and hopefully it gets better. Really, the key was letting them know that we knew it wasn't good. Like, okay, this isn't working for you. You're not crazy. You're not the only one. I think that helped us to rebuild some trust. And then that adaptability, just reevaluating goals. Maybe our goal and that promise wasn't what we should have been looking at. Maybe, keeping that dose of reality. Because when we get these cool technologies, it's really difficult not to dive in and just get so excited about the tool itself. But being adaptable to the humans, because that's really the whole point of this, is we're trying to take care of humans. And so divorcing humanity from technology just never quite works. So that's all.
And another thing to consider as Alex has caused us all to dream about things we could accomplish, is who your payers are. If they don't pay for it, you probably can't or shouldn't do it. So I know working at UNM, I was often jealous that Alex was working on something, because as a plan, Presbyterian health plan could be flexible in ways that UNM could not expect Medicare or Medicaid to be flexible as far as reimbursement. So there's tons of great ideas, and sometimes your payers are what's limiting you as well. And there was another question in the chat, Alex, from Dale, that said, doesn't the exclusive arrangement with Tyto Care leave out other patients not on the Presbyterian health plan who might also have gained benefits from using Tyto? And I chimed in and said that if you now buy a Tyto device at Best Buy, anyone, you use it and you're connected to a Presbyterian provider, because you as Presbyterian are delivering those services. And that does not mean you need Presbyterian health insurance or to use Pres. It's just when you connect to Tyto, the Pres providers are the ones that are meeting your needs. And he's responded with, what if you use providers not associated with Presbyterian? Dale, you might need to chime in, but basically if you're using Tyto, you're currently seeing a Pres provided provider, period.
Like a locked cell phone. So remember when cell phones used to be locked and you could just use them with one service provider? It's kind of what we're doing. But that is really only speaking to, I think, our commercial strategy there, which is really about exclusivity. Plain and simple, it is about exclusivity. However, as an integrated system, that's only half of the play, right? So we're also, we've given away 500. We're going to be giving away several thousand of these. And most of these households have a mix of patients and members and non-patients and members. And our philosophy is that you get one of these in a household or a community, and that's going to be a rising tide for everyone who has access to it. As well as some of our strategies to create hubs. So one of the things we're working on with the state of New Mexico is to place these strategically in areas of low access, agnostic to payer, agnostic to provider, and be a partner with the state to put these tools where people can make the most use of them. So that's a really good question. And I think it just has those two different lenses, the commercial aspect and the population health aspect.
Yeah, and Susan has chimed in and said she's seen an organization offering employer on-site clinics that can provide basic primary care with just an on-site nurse that's leveraging this type of technology. And absolutely, Apple, Google, a lot of the major companies that I'm talking pre-pandemic, when everyone is at an office, instead of leaving your office and going and seeing someone, you just go downstairs and go into a room and leverage one of these to see a provider. And it helps with productivity and making sure people are getting their annual visits and keeping their healthcare up. And there's just so many ways to leverage this for sure. I didn't know if you wanted to speak to that at all, Alex.
Yeah, that's a great point. We actually have a whole employer strategy. So we have one deployed right now with one of our employer groups in Albuquerque with several hundred employees. And then we've got one going live in January with many thousands of employees, and have about 20 other employer sites planned for 2023. So, and actually all of these are unmanned. So there's no nurse or MD on site or MA on site. It's a really great platform in that it's it's really user friendly. So as long as the provider's connected live, provider's really doing a lot of that instruction. They can see where you're putting it, know that your heart's not here, move it down. And so we've had some really good success with the providers navigating that process. These are great questions. Thank you.
And I know we're coming up on the end of the webinar. Is there any final questions for Alex? I'm guessing while you think about it, Laura, you're going to throw up the next webinar slide, perhaps?
I can. Hang on just a moment.
And we have Dale asking about health equity and exclusivity with products like this.
I don't know how much more I can speak to that intelligently, Dale, but I would love to refer you to Brian Brown and our on PHP, because I don't want to misspeak, because admittedly I focus on a little bit different part of this, the implementation aspect, but I'd love to connect you to someone if you're interested in hearing more about their strategies and how we are and how our population health group is involved.
Yeah, and to that point, I'm just going to go back to beat the dead horse with the payers. That was a concern when I was at UNM, was when the public health emergency goes away, and then all of a sudden you have New Mexicans who have a New Mexico health plan that we can bill for telemedicine for, but you've got New Mexicans with a Medicare plan that we can't bill for telemedicine for, and they call, UNM's phone center and say, I want an appointment. I would like to do telemedicine, but they can't, and maybe they can't drive, or because the drive is so long, they decide not to go into that care. I mean, the payer system in this country is also a barrier to exactly what you're talking about, equitable care for those, access, and it just feels really crummy to tell a patient, oh, I'm sorry, you have Medicare, you can't do this visit via telemedicine, even though it's possible and we have the technology and it would be best for everyone in many situations. And so that's another related problem to who's your payer that I mentioned earlier in your question, Dale, for sure. And I know Dale's, Dr. Alverson, as one of the fathers of telemedicine, is well aware.
Thank you for the really thoughtful questions.
Yeah, Alex, this is Dale. Can you hear me okay?
I can.
Yeah, I appreciate the dilemma, the conundrum, but I think a lot of us are really, when you think about social determinants of health and difficulties and challenges in patients accessing care, you want to make sure that there's reasonable equity and access. This issue comes up nationally about telehealth, that only those that can get get broadband, understand how to use devices, can't use it anyways. But I think we as healthcare providers need to be sensitive to and aware of the fact that we should try to always serve as many people as we can in improving their health and quality of life. So that's all I'm always concerned. This came up with us as well, an exclusive use of certain technologies that then, eliminated others who might be able to take advantage of it. So I appreciate the conundrum, but I'm always happy to talk to others who are dealing with it. But it's always that balance between market share and that commercial side, but then also making sure we provide the best care for everyone in New Mexico. So that's where I would come from. But by the way, your presentation has been great, and appreciate your willingness to share this with all of us. I don't think we have time, but I'll be interested more in understanding, and maybe Stetson does better than I do, what Doximity did, and how others might consider incorporating that to make it easier for patients to use the technology.
Well, if anyone wants me to send them a link, like basically a visit appointment, just put your phone number in this, or send me your phone number. And what I can do is I can just send you a mock Doximity invitation so you can see what it's like. It's really simple and just game changing in terms of that interaction. So you still
very
need a
interesting.
phone.
Yeah, Gistfully, it launches your visit through the web by clicking on a link that comes through a text message. instead of downloading an app and using the app and getting all the right codes and numbers in to see your provider.
And no logins,
realistic.
no accounts necessary. So
Yeah.
it's just show up.
It's as easy as watching a YouTube video.
Absolutely. Now, and
All right, everyone. Well, thanks.
Oh, so I just want to say to Dr. Alverson, I look forward to some of the things we're doing soon. And I think that once we're able to share some of the things we're doing with the state, I'd love to get your take on that too. I think it feels a little more aligned with the philosophies I think we all have.
Well,
Thanks.
thanks everyone for joining and all the questions. Thanks, Lisa and Lori, for helping put this on, and Alex for coming and presenting. I hope I see all of you on December 14th for the behavioral health challenges and how we can leverage behavioral health. And you have a great Wednesday afternoon.
Thank you, everyone. Thanks for having me.